Welcome to the Possibility Action Network podcast. I'm your host, Stephen Middleton, aka Possibility Man. We're committed to bringing you guests who strive to better people's lives and serve as a force for good in the world. Our guest today is Dr. Tyler Gonzalez. He is a board certified surgeon, researcher, and educator. He's a clinical assistant professor of orthopedic surgery at the University of South Carolina. He specializes in using minimally invasive techniques for foot and ankle reconstruction. Dr. Gonzalez completed his residency in orthopedic surgery at Harvard Medical School and further training at Cedar Sinai Medical Center in Los Angeles. His passions include improving patient care, medical education, research, and writing. He has published over 75 peer-reviewed articles and given presentations at professional meetings. Dr. Gonzalez is a healthcare entrepreneur with experience in biotech and health tech startups. Dr. Gonzalez, welcome to the show today.
Thank you so much, Dr. Middleton. It's a real honor to be here. Thank you so much for having me. I'm very excited.
Look, I've been looking forward to talk with you for several months now. But first, a reminder to our listeners and our viewers, follow, like, and share this podcast wherever you find it. Your support matters. It helps us attract guests like Dr. Gonzalez. Hey, Doc, you probably don't know this, but your patients love you. Many of them do because one of your patients told me that you would be an excellent guest on my podcast show. So that's wonderful.
Yeah, she was in my office and told me I had to reach out to you. And that's how we got connected. She's phenomenal. And no, I think that's one of the reasons why I do this is because I love taking care of my patients. They become not only my patients, but friends, and getting them back to life and having a good quality of life is very important to me. So, it's funny how this comes full circle, how you and I got connected. Kind of the purpose of your show, right?
Yeah, indeed. That is the purpose of my show for sure. Yeah, look, I wanted to ask you because you're a busy doctor, and I discovered before this morning that you're also a family man with young kids. So, look, what are your baby's names, your girls' names?
Yeah, I got three kids. My oldest is Sloan. Then my next is Savannah, and we just recently had a baby boy a couple months ago, Jacob. So my lovely wife Lisa is also here. She's taking care of the baby. But yeah, family's the most important thing to me. I think it's why I do what I do, and I love my kids and my wife, and I try to keep them involved. So as you can see, the viewers can't see, but my kids are running in and out of my office. I try to keep them honestly very, very engaged with my life. I mean, as a busy surgeon, you can be gone a lot. So I try to keep them very active. So my kids come to the hospital with me. I mean, I had a sick patient in the hospital last weekend. My two girls made get well cards for her and came to the hospital with me and actually gave them to her. And for them, that they get to see the type of patients. I think my patients, it's really nice for them. And also it shows my kids what I do for work, right? They just don't hear it, see dad's gone all the time. They live it. They come to my office. They know my staff. When I look at x-rays or MRIs on my computer, they come in. So they really actually know what I do and who I take care of, which I think is important. So they know when I'm gone, I'm just not gone. They see that I'm helping take care of people and that I'm working to make people's lives better. And also that's my job and how I provide for the family. So gives them a little education as well.
That's fantastic. And gosh, from what I can tell, you got this thing balanced. I know it's not the perfect balance, but it seems that you know how to balance your life, family as well as work. So that's awesome. Hey, look, so tell me about your background, your educational background, starting with college.
Yeah, so I went to I'm from California, and I always had a strong interest in science. Growing up, I liked science and math. I initially thought I wanted to be a veterinarian because I loved animals, still do. But then I in high school I rotated through the hospital, and very charismatic. I always like people, and I was like, wait, I could take care of people instead of animals. I think I'll do that.
Mm.
And so
Wow.
I kind of set out on a path for medicine. I went to UC Berkeley for undergrad. I majored in nutritional science, as I thought that was just something very applicable to medicine, and I really enjoyed that field. From Berkeley, I then went to UCLA for medical school. I actually did a combined degree, so I did my MD and my MBA. So I went to business school at the same time. It's a combined degree. It's 5 years. The reason I did that, this was almost 15 years ago. I just thought I wanted to do business school at Berkeley, but it really didn't allow you to be a pre-med and a business major. They were just too
Mm.
competitive, and it really all the classes were at the same. They really wanted you to choose one path. So I thought medicine, as it has grown, as you know how big of an industry it is a business.
Yeah.
Whether you look from the hospital side, the healthcare side, insurance side, medical device side, it's all a business. And so I felt that I could provide, and even the research side, grant funding, grant writing, it all is a business. And so I knew I could master the medicine, the patient care part, but I wanted to make sure I understood the business side so that I could provide the best care through both worlds and also be a liaison if needed, right?
Yeah.
And so I did my MBA, and I focused on both entrepreneurship, but also healthcare management, which was really great in business school. And that's where, as you mentioned, I had worked in some biotech at that time and helped with some startups. And one of the things I'm gonna digress, and I can talk a lot, but I'm gonna do one spin and come right back to answer your question. But
Okay.
in my life in healthcare, I have always thought, and everywhere I've interviewed, I have my hands in many pots. I like to
Mm.
teach, I like to do education, I like to do research, I do product development and design new surgeries and new surgery implants. And I'm a surgeon and take care of people. And people are always like, why do you do all this stuff? Why don't you just stay in one lane? Stay in one lane. Well, ever since I was in undergrad, I always told everybody, I'm only one person. No matter how hard I work, how hard I try, I'm going to only be able to physically fix or help so many individuals. But if I can teach 10,000 people that then can take care of 10,000 more patients, and I can do research that changes the way a surgery is done to improve patients, and then I can design something or create something that then changes. Now I have exponentially affected healthcare and people's lives. So,
Indeed.
so, so that's why I always said that. And that was always, since a young age, I always felt that's how I can do more for patients. It's not just me. It's about everybody. How can we all make it better? So in business school, this biotech was to learn how can I help be involved in designing or developing something that may affect millions of people's lives. And we actually worked on a very cool test to better identify, like it was a device to identify pathogens like anthrax or bacteria. So the military could use it, doctors could use it. And again, using my medical knowledge, my research background to help foster that was very exciting. So that's how I got involved in that. But then I spun back around, finished medical school, business school, went to Harvard for residency, did residency there in Boston, which was a great experience, and then wanted to focus on foot and ankle surgery. I really liked it. I thought I could take care of elderly patients, kids, sports, with every problem. Went back, did my fellowship at Cedar Sinai, and then finished that, and now I've been in practice, and so that's kind of how I got to where I am.
I got you. Hey, look, you said so many things that we're going to dig in a little deeper. But let me roll back though, because you mentioned shadowing a medical doctor or medical doctors in high school. So I got to ask you, when did you get the bug I'm going to pursue medicine. It was before college. When did you get
Yeah.
that?
Yeah, it was like I said, in high school, I was just always a kid who was I would say twofold. I just my mom was always a very genuine, caring person, always did a lot of
Mm,
charity work, a lot of helping. So I think that was kind of in my blood, always about giving back.
yeah.
And then I was
Okay.
always into science and math. And so I did classes where we did just science experiments, math,
Mhm.
animal dissections, things like
Okay.
that.
In high
Learning
school.
about
Okay.
in high
Yeah.
school or middle school,
Mm.
actually. It started in middle school. And
Okay.
then in high school, that's where then I just volunteered my time in summer to help out at a hospital. And when I
Uh-huh.
did that and saw how you could kind of combine all this really interest in science and biology with
Yeah.
helping people, it just kind of made sense to me, right? It's
Right. Right.
like,
Okay. Yeah. Yeah. But look, I mean, so from college, from the
yeah.
start of college to finishing all of your training to being in the room as the surgeon, how many years are we talking about?
Um, so from college, so it's 4 years of college. Then I did 5 years of medical school, business school. So that puts you at 9. Then you do 5 years of residency. So that puts you at 14 years. Then an extra year of specialty training just in foot and ankle is 15. And then you start being on your own. So
Right.
from the day you graduate college to
Mhm.
then and I actually took a year off between college and medical school because
Mhm.
applying for medical school is very expensive.
Mhm.
So I had to work to kind of pay for my application. So I took a year off. I was a tutor. I was a private academic tutor for like high school kids to fund my med school applications. And then so it was 16 years to get to finally be able to take care of patients on my own.
Right. I mean, it's good for us to know, good for your patients to know that there's a lot of training that goes into what you're doing. So now, when did you decide, I'm gonna specialize in surgery? And then I want to go step by step from surgery to orthopedic surgery. When did you make that decision? What influenced your decision?
Yeah, so great question. I think one of the funny thing was I didn't even want to be a surgeon. So in medical school, the way for our audience, the way it works is you don't know, you can choose anything, right? Family medicine, anesthesia, surgery, and you really make that decision around your third year of medical school because in your fourth year is when you start doing what's called like sub internship. So if you're going to be an intern
Mm,
at IBM, you would go do an internship, or if you want to work in tech or anything, or finance, you would go do an internship at JP Morgan Chase or something like that. Well, in medicine, it's the same. When you're in your fourth year of medical school, if you want to be an emergency medicine doctor, you do these 1 month internships throughout the country at various hospitals, and then you go interview for your residency in emergency medicine.
mm,
So you kind of have to decide by your third year. Well, interestingly enough, I had one of our surgery mentors at UCLA. He said to us when we were first years, giving us lectures as in surgery, he's like, if he goes, many of you are probably thinking about surgery. Let me tell
mm,
you one thing. When you go on vacation, when you go to bed at night, if you dream of surgery, if you're on vacation and the only thing you can think about is getting back into the operating room, you should be a surgeon. If not, do not be a surgeon. And I was
mm,
like, oh, that's kind of weird. Okay, well, I don't think I want to be a surgeon then. And I
mm,
actually wanted to be a pediatric cardiologist, is actually
mm.
what I wanted to do. I loved working with kids. I love the heart. I thought, these kids with terrible problems, you could really help and bring them a huge quality of life. And so, however, in my third year, third year of medical schools when you start working in the hospitals. So you have to do rotations in every specialty: family medicine, internal medicine, emergency medicine, surgery, OBGYN as part of your medical training. So I was pretty set on pediatric cardiology. I get to my 30-year rotation on surgery, and I was, back in those days, we didn't really have many work hour restrictions. So I remember on my first day of surgery, my chief resident was like, okay, you're going to round on all the patients first. Then the resident's going to come in and meet with you. You're going to round again. And then I'm going to come in and you're going to meet with me and we're all going to round. So get here before the resident does. I was like, okay. So I would get there like at 3 a.m. I'd round on all the patients and then we'd round again and then we'd round again and then we'd go into surgery. And I remember after the first week, I was like, oh man, I have to do surgery. I was like, this is great. I was like, I just actually loved being in the operating room and operating. And I think the reason was there was a very tangible problem that you set out to fix. So it was like problem, solution, like surgery to fix it, and then with the hopes of making the patient better. And I'll tell you, I didn't care about being up early, staying up late. I just really, really enjoyed it. And that's when I was like, okay, well, so it was very quick. It was one of those things where within a week, I was like, oh, I think I have to do surgery. And I went back to my mentor my first year, and I was like, yep, I am dreaming about being back into the OR. That's all I want to do. I want to get back into the operating room.
Yeah.
So, and then from there, it was really the journey to orthopedic surgery. And I'll be honest, it was very simple to me. I just like the people in orthopedics. I
That's
like,
great.
I like the people. I liked the doctors. I liked their mentality. And honestly, the patients, I liked the idea that in orthopedic surgery, a lot of these patients have a musculoskeletal problem that's really affecting their quality of life. And that is playing sports to as simple as chasing the kids around, the grandkids around, going shopping, driving, walking down the beach. And so throwing a football. So I like the idea of that I could help those people really improve their quality of life. And so that's how I got to surgery and then orthopedic surgery.
Great story. Hey, look, so what would you say are the characteristics of a surgeon? Now, there will be some pre-med students watching this, some medical students even. What are some characteristics of a surgeon?
Well, I'll say that not every surgeon is the same, and I'll say not every specialty is the same. And I think if you look at plastic surgeons, orthopedic surgeons, general surgeons, ENT surgeons, everyone has a little different, culture and stigma. I mean, orthopedic surgeons, I can say this, we're known as the meatheads, right? That's like kind of we're stereotypical of that, but there's a little truth in every rumor, I think. So, but I think most surgeons in general, right, they're very meticulous, right? There's a lot of type A personalities, really, really meticulous attention to detail. I think not that anyone else is not hardworking, but I think surgeons are really love the grind, right? They do love the grind, and they like being able to solve problems, like real. And what I mean by that is definitive solution. So you have an appendicitis, the appendix comes out. You have a broken bone, the bone gets fixed, right? There's a surgical solution to many problems. So I think that, and I would say you like to work with your hands, right? That you like the ability to fix something, but not only with your brain, but also with your hands, right? So I think those are some characteristics, and then I think it's really important that you like to deal with patients, because unlike seeing them in the office, you see them in the office and in the operating room. So you have a real intimate relationship with your patients, because your patients, and I say this truly, I say this to all my patients, you really put your lives in our hands. And I say that because even if it doesn't matter what surgery you're having, it could be a heart transplant or a bunion, you're going under anesthesia. you're going under the knife. So you were really trusting your life with your surgeon's hands. And so you have to, as a surgeon, you have a special bond with your patient. And so I think
Yeah.
that's one characteristic of us that we have, that we want to be able to have that bond with them.
Yeah. Speaking of patients, when patients come to you, what are some of the common problems that they present, the clinical presentation? Let's do one by one. Let me throw a few of them out. Do patients come to see you who have, let's say, bone spurs?
Yes, all the time. Very common.
Yeah. Yeah. So what, what do you do? I mean, how do you you're looking at a person's foot? How do you know it's a bone spur? I mean, I don't know.
Well, a lot of times, one, the two key elements for me are a story, or three, I should say. Their
Okay.
story, their physical exam, and
Mhm.
usually their X-rays or their MRI or CT scans, their imaging. And
Mhm.
bone spurs are actually usually are caused by early arthritis. But really, like anything, they just block motion, right? So they usually occur at a joint. And so when you have a bone spur, they either rub on your shoe or they block motion of the foot or the ankle. So most
Mhm.
people come in and say, I have a knot on my foot, something's rubbing on my shoe, or it hurts. I can't bend my toe. I can't bend
Mhm.
my ankle. And so the story, and I tell my residents and medical students, you can probably diagnose, at least in orthopedics, most problems by the story, right?
Mhm.
The patient can tell you their story, and you usually about 90% of the time can figure out what it is, because we're a mechanical field, right? We deal
Mhm.
with muscles, bones, tendons, ligaments, joints. So a lot of times the story is the key element for us. So I tell my residents and my medical students that's what they need to focus on: asking the right questions and
Mhm.
listening to the patient, because most of the time, if you just sit and listen, they'll tell you what the problem is through their
Mhm.
story. But then a physical exam is very important, right? You can usually feel it. Most people say they got a knot on their foot or a hot spot, and you can feel it. It's literally a bone spur. It's a bump. You can feel it. And then we get X-rays, and on
Uh-huh.
X-rays you can see it. So that's
Okay.
really it's pretty simple.
Yeah. Okay. Well, it's simple to you, doctor. Yeah. Well, let me throw another one out to you. Hammer toe. Hammer toe.
Yeah.
Um, yeah. So I mean, it's visual, right? So, tell us what is a hammer toe? What is that?
Yeah, so a hammer toe. Oftentimes, one of the also the most common things is a bunion, right? The bunion and the
Uh-huh.
hammer toe often come together, and most people think of the bunion on the inside of their foot. It's a little bump, but it's a crooked toe, right? The
Oh.
bones are moving apart, and so your bone is actually starting to protrude on the inside of your foot, creating that bunion. And when the top of the toe starts coming over, you get a hammer toe, and that a hammer toe is when your toe starts to bend, right? And you get
Uh-huh.
that knuckle starting to bend, which really can bother both men and women. People think it's a women get a lot, but I see a lot of men who have it as well. And that hammer toe can really irritate people with shoe wear, because that knuckle really starts to bend up. The tip of the toe can start digging into the ground, which can hurt.
Mhm.
And oftentimes it's not always associated with a bunion, but it can be. And I think, so I see a lot of patients, and mainly both men and women, it's problem with shoe wear,
Mhm.
sometimes problem with balance. And I think, as you mentioned earlier, I focus on a lot of minimally invasive surgery. So this is one of my most common surgeries I do. I
Mhm.
do it very minimally invasively through some very small incisions, and get people on their feet much faster than traditional methods and with much less pain. So I
Uh-huh.
think that this minimally invasive surgery that I do has really changed my practice and my patient care,
Uh-huh.
because I think it's really improved their function a lot faster and minimized their pain, and it sped up their recovery tremendously.
Uh-huh. Dr. Gonzalez, okay, let's say that a person sees that the toe, that they have hammer toe and a bunion. They see the big toe but now
Yeah,
they know
yeah.
it's a bunion. So, but they're not in pain. When should they come to you? How does a patient know when to see you for just those two things?
Yeah, it's a great question. I think the most really they can see me. I tell them whenever they want, right? I'm here to provide, to not just do surgery, but also to provide education. So if you don't know what it is and you're worried about it and you want to know what to do about it, you come see me. I think the without a doubt question is when it starts causing a problem, right? If it's really rubbing on your shoe, impairing your quality of life, you can't find shoes that you wear, you're limiting your activities or changing what you do because of it. That's the no-brainer. That's when you come in, because there are solutions for that to get you back to your quality of life. But even if it's something that's not bothering you and you just want more information about it, or if there's ways of preventing it from getting worse, that's what we're here to help you figure out.
Uh-huh. That's good news. Good to know. I'm not sure if there's a thing called dance medicine or not, but I can imagine ballet dancers,
There is,
people
there
are very
is.
acrobatic in their dancing. Do they come to you for problems, and what kind of problems do they tend to present?
Yeah, actually, when I was in fellowship, I was one of the team physicians for the LA Ballet out there
Mm,
in Los Angeles. So I've worked with a lot of dancers in my life. They pound their feet. Dancers, they are the tough as nails. They are so tough, and they really put their feet through work. So they do get a lot of problems with their feet, both their toes and their ankles. So
mm,
we take care of a lot of them.
mm,
Not and a lot of times it's not surgical. Sometimes it is, but it's we don't like to operate on dancers if we don't have to, because we like to keep them flexible and moving and don't want to take them
mm,
out. If we do, we do surgery, and I do surgery on them. But yeah, they have a lot of foot and ankle problems, and there's a lot of great dance medicine institutes out there. Tim Charlton was one of my mentors, great dance medicine physician
mm.
out in LA, trained in New York, a phenomenal guy. So there's a lot of great dance medicine institutes, and a lot of dancers with problems. So we take care of a lot of them.
Uh-huh. Uh-huh. So this question, but I got to ask you because it occurred to me, and God forbid, but do children, infants, come into the world with birth defects of the ankle and foot, and do you see them?
Yeah, they do. One common
Mm,
one is club feet, which we are usually able to treat without surgery. There are other congenital problems that kids have, that they come in, and some don't manifest in infancy. They are later on in their life.
mm,
I deal with a lot of those at times as they age and mature, they develop problems. One of the big things that I treat is what's called Charcot-Marie-Tooth. It's
mm,
uh it's a congenital disease that affects both the motor and sensory nerves. So the nerves in your body that provide motor function, so your muscles, and the other ones that provide feeling. And a lot of times, kids, and this causes bad deformities in the feet, clogged
mm,
hammer toes,
mm,
like you talked about, but
mm,
also the feet turn in, very hard time ambulating. And it's a progressive problem. So you
mm,
don't always start out of it with kids. I treat adults with it and kids, but in children, sometimes they get it very young. And I treat kids for this from all over the world, all over the country. I mean, kids
mm,
from New York, Florida, California, Texas, families, because it is congenital, so it comes through the family. So most time,
mm,
all a lot of the family members have it, and
mm,
again, one of the reasons I like treating it is because I can't treat the disease, right? Like I can't
mm,
cure them of Charcot-Marie-Tooth. But what I
mm.
can do is I can fix the physical manifestation in the
Uh-huh.
feet and improve their function and
Yeah.
really get kids. I mean, I remember I had one girl who had never really worn flats or normal shoes. And
Mm,
after surgery, she sent me pictures of her wearing normal sneakers, and that was like
yeah.
such a great feeling for her to
Yeah.
do that.
Mm,
So, those are some of the things in children and younger kids we take care of, but also adults.
yeah. Yeah. And I mentioned in introducing you that you teach at the University of South Carolina. That's big time college football. So
Big time.
do
No
you see
cop.
any? Yeah,
No cop.
yeah, yeah. Do you see any sports related injuries in your practice?
Yes, yes. So we take care of my partner and I take care of all the athletes. He's actually one of the my partner's one of the head team physicians. for the Gamecocks for the football and basketball team. We take care of the dance team, the cheerleaders, all the athletes there. My whole practice does, right? So the baseball players, they all have, and again, baseball players they get injuries everywhere, a lot of shoulder, elbow problems. Basketball, football players have a lot of knee, ankle, foot problems. And so in my practice, I do take care of and a lot of recreational athletes, high school athletes, and there's a lot of college athletes, D1, D2, D3 athletes that we take care of as a group, and that's really great too. Some of these are chronic injuries, some of these are fracture, like we see on TV, breaks of the ankle, breaks of the foot, and being able to get these athletes back on the field is a real passion of mine, and I really enjoy it. So yes, we take care of a lot of them.
Now, you also do reconstruction surgery. So that suggests to me that a patient may present with some real trauma of the ankle and foot. Can you tell us, what kinds of things have you seen, and have you been able to restore someone like that to health? Either sports, automobile accident. I just can imagine all kinds of trauma to the ankle and the foot might come into your office.
Yeah, so reconstructive really, really the way I think about it is kind of rebuilding, right? Like as the name implies, right? So as in the last example, the Charcot-Marie tooth, I mean, they come in with a foot, they're walking on the side of the foot, literally on the outside of their foot. So we rebuild it through cutting the bones, rearranging the bones, rearranging the tendons so they walk flat. That's one example. Another example is you gave an automobile accident. So a lot of times if you have a bad automobile accident and break the ankle and the foot, I put it back together, usually with plates and screws, and rebuild the foot. And oftentimes we can rebuild it and people do great. Other times we can rebuild it perfectly, but they still then can develop bad like arthritis, right? So they can develop bad arthritis. So then what I can do is I can go in there and remove the arthritis and, for example, put in an ankle replacement, like a new ankle made of like a hip replacement or a knee replacement. I can go in and replace the ankle and reconstruct their arthritis, giving them a new ankle to improve their function. So there are many various options. One more example is I see patients who get treated for a break or treated for arthritis and they don't heal. They don't heal right. So then I have to go in and redo it and rebuild it a second time and get people really back on their feet. So the reconstructive surgery for me is a real passion. I've worked on some techniques to do it less invasively to minimize wounds and soft tissue healing and infections, which we're currently studying now, which is really working well. But the reconstructive is a big passion of mine. Again, these patients, as you said, they go through a lot of trauma, a lot of surgery. So trying to get them really back to functioning is tough work, but it's really gratifying. It really is.
You mentioned, like, I never thought of this one. You said remove the arthritis. What does that mean? Removing the arthritis.
Yeah, so we can a lot of times when the people have the arthritis in the ankle or the foot, we take it out, and then like in the ankle, we replace the ankle joint with an ankle replacement, so metal and plastic. So we take out the arthritis and then put metal and plastic in there to give them a new joint, which doesn't hurt anymore, theoretically.
Wow. Dr. Gonzalez, what is the most rewarding part of your job? Or at least one of the most rewarding part of your jobs.
I mean, honestly, it's just improving patients' quality of life. It is really, that's what it is. So that's the most rewarding thing. That's what it gives me the gratification, and that's what keeps me going is, those patients who the patient comes in, I had a kid who was not a kid, he's 23. He had 4 different surgeries on his feet, couldn't walk. We did a fifth on each one, got him back walking on his feet. I did it 2-3 years ago. He told me he lost 120 pounds, back to life. Couldn't be happier, right? Another patient of mine who, it's little things I think we all take for granted, who,
Mm-hmm.
I did a surgery on her foot for what's Achilles tendonitis.
Mm-hmm.
She was very limited in walking, couldn't walk with her husband, couldn't walk on the beach. They live on the beach now. She's like, I have no pain. I can go on walks at night on the beach, and that's all I've wanted to do for the last 4 years. Right?
Wow.
Like just little things that we don't even think about, but
Mm-hmm.
that change people's daily lives,
Yeah.
and that's why, again, why I went into this field, and that provides me the most gratification is making people happy again or enjoying their
Yeah.
lives again, because life is precious, life is short, and if you're constantly in pain or can't do the things you love, like just walking down the beach, if I can give you that back,
Mm.
that's phenomenal.
Yeah.
That's what I
Like,
want to do.
oh boy. Yes, yes, indeed. Hey, look, approximately how many surgeries have you done? Approximately.
So, I would say, like, through if you include, I mean, if you include everything, let me think here. I probably do about 500 to 600 surgeries a year. And
Wow.
so, and so if you include everything in my training, I think we're probably pushing about, including my training. I mean, oh man, I just got to think here. It's like maybe about 8 to 10,000 in,
Whoa. Yeah.
including all my residency training and fellowship, something like that. Yeah.
That's a lot of surgeries. Wow,
Yeah.
that's amazing. So look, I want to talk now about surgery tools. I mean, whenever I visit doctors' offices, I see all these new gadgets that weren't there 50 years ago. So, and many of us watch TV. We watch The Good Doctor, Grey's Anatomy, surgery tools. So my first question to you is that how has, well, firstly, yeah, how has AI, artificial intelligence, influenced surgery and the tools used in surgery?
So I don't know right now. I think we're figuring out the best way to use AI in general in healthcare, which it's a whole nother topic. But if we want to focus on
Mhm.
surgery tools, one way we're trying to explore AI and how we can help us is more with doing, I would say, more accurate or more precise surgery. So, in some of the things we do, hip and knee replacements, ankle replacements, we use navigation to make sure that we're doing the most accurate surgery, and what we call, when you're doing a replacement, you're often cutting out the arthritis. So making sure you're cutting out the right amount of bone in the right
Mhm.
shape, because you got to put it in, just like if you were to mount a picture on the wall, it needs to be level, right?
Yeah.
And the right size and the right bracket. It's the same when you put it in an ankle replacement. It needs to
Mhm.
be level in the right orientation, but in 3 dimensions. And so we use some AI to help make those more accurate. They're exploring ways of using AI, in example, in resecting tumors,
Mhm.
right? Using helping with headsets and things in the OR, where you might be able to visualize the CAT scan or the MRI in surgery on the patient to be able to resect the tumor in its entirety. Um, so I think we're using it in augmented reality in surgery, and those are ways. But we're still figuring out the best way to enhance utilizing AI in terms of the tools. I still think that one of the ways that we're utilizing it the most right now, we use a lot of surgeon expertise in
Mhm.
development. I do a lot of product development, so I'm involved in designing several surgical tools for minimally invasive surgery. And I'm part of these design teams that do that. And a lot of that comes with experience in these various surgeries, trying
Mhm.
to develop what is going to be the most efficient, most reproducible way of performing the surgery. And then that comes with experience and working with the engineers to do that.
Mhm. So you've been in practice for, I think, over 15 years now. Um, what do have has your ability to look inside a patient's ankle or foot improved due to technology over over 10 decades?
Yeah, there are a lot of ways that we have improved visualization through instruments, more minimally invasive ways, utilizing cameras to look in, uh, whether we used to do big open surgery using cameras arthroscopically to go in and be able to fix things and
Mm,
visualize things better have definitely improved. And now with certain surgeries that you use navigation, computer assistance, augmented reality, those have also started. Now they're not. I wouldn't say they're where we need them to be, but they're on their
mhm.
way.
Uh-huh. So look, I want to talk more. You already mentioned some of your research interests in your inventions. So I'm going to look at your research now, especially the kinds of tools. I was going to say gadgets, but I think that would be appropriate. Tell us about some of the things that you have invented.
Well, so like I said, I'm not going to take. It's not. I wouldn't say all me invented. I've always worked with engineers and other surgeons, and it's been a collaborative effort. But I think when you're designing surgery instruments, this goes back to what we talked about in the beginning. If I can create something that I think will either change a surgery that's done, or make a surgeon better at it, right? Make it more reproducible, make it less likely to have a complication, then my outreach of patient care is really getting bigger. So
Mm,
some of the things which I've worked on are some new minimally invasive bunion system that recently launched a couple months ago to do bunion surgery less invasively and improve our outcomes. I'm currently working on a minimally invasive system for Achilles tendonitis, so really something called the Zadic osteotomy. We've published a lot about this surgery. I think it's a game-changing surgery for what we call insertional Achilles tendinopathy and Haglund's deformity. We published about 5 papers on this in the last year. It
mm,
is a surgery that actually, and this is what we were talking about earlier, this surgery existed in the 1930s. This is not a new
mm,
surgery, but with it was done what I mean by open through big incisions, and they had a lot of wound complications.
mm,
So it's kind of abandoned. With the advent of more minimally invasive techniques, this surgery historically worked exceptionally well for this problem, but the risk of the wound complications, it made it fall out of favor for other techniques.
mm,
Well, with the advent of more minimally invasive surgery, from going from a 5 centimeter incision to a 5 millimeter incision,
mm,
it has really made a resurgence. And in my opinion, I think really is going to be a first line treatment for this within the next 5 years, simply because it's so minimally invasive.
mm,
People's recovery is much faster, probably 70% faster, as
mm,
well as a faster return to work activities. And so I'm working with a great team of surgeons, hopefully to have this out in the next couple of months, of a
mm.
system to be able to perform this surgery and make it reproducible, right?
Got it.
And easier to do. So
Mm,
that's a and then there's some other things I've developed, what we call soft tissue anchors to repair
mm,
ligaments and tendons, made them very small, bioabsorbable, very powerful, which I think are some of the best anchors on the market. And again, this is less invasive, easy to do, and ultimately to improve patient care. So these are some of
mm,
the things that I have worked on more recently and have been pushed out in the market, and we're getting great results and more to come on those. But again, that's why I do it. I like to take my passion for specific types of surgery,
mm,
innovate on it, so that more people who may be somewhat timid of it, or because sometimes I will tell you, Dr. Milton, minimally invasive surgery can be, it is a little more technically challenging. It does. It is a little harder to learn. And again, it's something I never learned in residency or fellowship. I was self-taught. So when you're in practice, it's a little hard to change. The reason I changed was I saw the benefits to patients.
Uh-huh.
I saw that this was less painful, less wound complications,
Uh-huh.
faster recovery. So I wanted to be able to give that benefit to my patients. So I
Yeah.
think as I grew in this, I wanted to try to find solutions to other surgeons so
Uh-huh.
that they could provide this to their patients too. And so that's where the
Yeah.
research comes to show them that, hey, look, I'm doing this and it works. And then where the innovation comes in creating tools and instruments to allow them
Yeah.
to get similar results.
This sounds so exciting, but I got to ask you, this is probably the toughest question that I will have asked you today. Where do you, if you had to put your finger on, because you talk about innovating a lot of stuff, innovation, where do these ideas come from? If you were to put your thumb on it, your finger on it, where would you say they come from?
I think like anything, to be honest, it comes from complications and problems with surgery.
Okay. Okay.
So when the only way we advance any field is through analysis, right? And in
Uh-huh.
every field, medicine's an imperfect science, but everything, no matter what it is, whether it's construction, finance, medicine, there's failures. Failures occur. You have to analyze those failures and figure out how to be better so those failures don't happen. In surgery, if you look at, everyone knows laparoscopic surgery. I mean, they used to do big open surgeries. And then once they developed the camera to do things, they developed ways of removing the gallbladder and the appendix laparoscopically, which decreased the rates of pain, infection, bowel obstructions, things like that. So it all stems from innovation, stems from failures or complications so that we can improve patient care. So in a lot of these surgeries, when we're doing them, if you constantly say, is there a way we can do this better? And there's usually is. And if that way is, if there's a driving force to make it better, that's where this innovation comes. And it requires all of us as physicians to constantly not just accept the status quo, but figure out,
Yeah.
can we make this better? And I think one thing, that's even, is like an Achilles tendon repair. I mean, for years, people did this open, and over the last 10 years, we find ways of making the incision go from 10 centimeters to 7 centimeters to 1 centimeter with the same outcome, but less pain, less complications. So that's where the innovation really, I think, for us to be better, to provide better care to our patients.
So look, I mean, you're a busy doctor. You're the CEO of two companies, co-founder of one very busy doctor. So I'm just kind of curious, how do you keep yourself from burning out?
Yeah, I think it's a big problem in medicine. I think it is a big problem that we don't have a good solution for. I will tell you, and I tell my residents this, and I literally had this conversation with someone at dinner the other night. I actually think doing all these things helps me not burn out because it gives me a lot of gratification. It gives me a lot of purpose. I don't do the same thing every day. So I am constantly doing something different. I'm seeing patients in the office, I'm doing surgery, but then I'm teaching, then I'm doing research, then I'm innovating, then I'm spending time with my family. And having that little balance, I think, helps balance me personally. And allows me to really love my job because I'm able to do um, uh, uh, a little bit. I do a little bit of everything, but it all comes back to patient care. It all comes back to improving the outcomes of my patients, and I think, and I'll be honest, I enjoy it. I
Yeah.
love taking care of patients. I love operating, but I love teaching. I love researching. I love studying why things work, why they don't work, how we can improve it. I love innovating. I love creating, and so I think for me, knowing those are passions of mine, if I were to just give them up and not do them, I think that's when I would burn out because
Yeah,
I don't think it's as much on my plate. It's like what wouldn't be on my
yeah,
plate. But yeah, my wife keeps
yeah,
telling me I have to say no, so I do
yeah.
that sometimes.
Well, yeah, I tell you what, you found your calling for sure. So look, how do you stay healthy? I mean, let me roll back. First question: is surgery, being a surgeon, a young man's game?
Um,
Is it a young man's profession? Yeah.
No, I think anyone can do it. I mean, I think one thing in surgery, I think it takes time to really get good. I think, I think it takes a lot of experience, just like anything. So I think that it's not anyone can do it. It's just about if you want to do it. And it's just you got to learn how to do it. You got to train for it, just like anything, right? You got to train and put in hours and hours and hours. It's a 10,000 hour rule. You got to keep grinding to get good at it. And I think, as you age in surgery, you get better because you experience both the good and the bad, which makes you
Mm,
better. Um, I think in terms of your question about how you stay healthy, so I think this is really important. It's really important to me. I think exercising and sleep are and diet are really, really important. They're a big focus of mine. I actually have a pretty regimented schedule. I try to work out about 4 days a week. So I do a lot. I do yoga 1 day a week. I ride a
oh,
bike 1 day a week. I row 1 day a week, and I lift 1 day a week. And I usually do that in the mornings before, around 5 a.m. I work out for
mm,
20 or 30 minutes. That's it. But I do that every week. Uh, I try to eat fairly healthy. I do intermittent fast, which I've been doing for about 8, 9 years. So,
mm,
which I think is, you know, in my opinion, a really healthy. But
mm,
I do that, so kind of, some people they don't eat breakfast, but I usually don't eat from 8 p.m. till about noon or 1 p.m. And I found that's given
mm,
me more energy and I think really, really helped me stay healthy. And then I think sleep is really important. I used to think that I didn't really need a lot of sleep. I think as surgeons, we're like, we don't need sleep, we can go. But I really
mm,
found that I try to get to bed between 9:30 and 10:30 every day, and I wake up at 5:10 every single day of the week, Monday through
wow.
Sunday, pretty much. And that 7 hours of sleep, I think, is pretty key. And I started doing that a couple of years ago, and I really think that's made a big difference. So
Mm,
I think habits are important as a surgeon, as a physician, and we all get lost. But you before you can take care of others, you got to take care of yourself because you can't take
oh
care of
boy.
others if you don't take care of yourself. So I want to be around for a long time. I want to see my
Mm,
kids grow up. I want to be a grandfather, hopefully. And so I think I try to stay healthy. And I think we don't have to kill ourselves with exercise, right? Like I
mm,
said, I do 20 or 30 minutes. Honestly, it's usually just 20 minutes a day. And I think, but you do it every week, right? And you
mm,
just keep up the routine, and you ain't going to see results in a week. You ain't going to see results in 3 months, but over the years, you will just notice yourself
mm.
have more energy, feel more fit, and then it becomes part of your daily routine, and it's easy to do. But
Yeah.
you got to make it part of it. You gotta take care of yourself. It's very important.
Yeah. I mean, a lot of people are talking about nutrition. Some people say do plant-based, others say be a carnivore. What kinds of things do you eat? What do you have a favored nutrition plan?
Yeah, it's so I will say I think there's always something new out there. I don't know what's right. Um, I do not have the time to study it all, but one thing I try to focus on like the blue states. I really think a Mediterranean diet. I have a lot of olive oil in my diet. I I do I think there's a lot of I try to stay away from a lot of high ultra processed foods. I do. I said I think intermittent fasting. There's a lot of I nerded out on this. There's a lot of science on it. It's not the diet, just intermittent fasting itself.
Mm,
Where you allow your body to repair itself. I think it's shown a lot of benefits from diabetes, cardiovascular disease, cancer. So I think at least one thing people can do is research that, see if that fits them. I do it. I'm not an expert in it, but I do it, like I said, from 8 to 1 usually, and I've seen a lot of health benefits from that. And then what I normally do, honestly, I eat usually nuts and berries for lunch. I'm not gonna lie. Almonds, pistachios, and walnuts with some raspberries or blackberries for lunch. It's usually all I have every day.
Mm.
And then honestly, what I eat for lunch is what my wife makes for my kids. My
Mm.
wife cooks pretty healthy. We usually have some type of meat and vegetable.
Mm.
But again, I eat whatever she makes, but I don't limit myself. If we're going
Yeah.
out to dinner and eating Chick-fil-A or going out to dinner, I'll eat what I want because I love food. I'm a big foodie. And so I think that with exercise and eating in moderation is really important. I don't really drink soda, drink a lot of water, have a lot of olive oil. I
Mhm.
think those few things most people can do, and I think I drink coffee
Yeah.
black, but that's personal choice. Sometimes I'll add a little creamer if I want, if I got a sweet tooth. But again, you only live once. I ain't gonna torture myself all the time either.
Uh-huh. Well, I tell you what, Dr. Gonzalez, I hope that I never need surgery, but if I ever need foot or ankle surgery, I'm going to find you because you're amazing. So,
You call me. I tell all my patients. I said if I get you better without surgery, it's better for both of us. But if we have to operate, I'll take good care of you.
well, look, it has certainly been a pleasure talk with you today. I mean, surgery just sounds so exciting. If I were younger, I would become a surgeon because of you. So, thank you for sitting with me.
Well, that's fantastic. I mean, it's a true honor to be on your show. I hope I added something to it. And please, if you ever need anything or any of the audience has any questions, please reach out to me. Happy to talk to anybody. It's been a real pleasure this morning. Happy to do it.
Okay. Well, there you have it, folks. You've been listening to the Possibility Action Network podcast. Our guest today has been Dr. Tyler Gonzalez, an orthopedic surgeon. I'm your host, Stephen Middleton. Until next time, good day. You are not alone, just keep on.